Hello, dear friends. Today we have a very interesting and very important topic, as well as an equally interesting and important guest. Today we are going to talk about oral cavity oncopathology, or in simpler, more understandable terms, oral cancer. You will learn how to detect these precancerous conditions in a timely manner, how to effectively prevent their development, how to comprehensively treat them, and most importantly, what crucial steps to take if, God forbid, you are unfortunately diagnosed with these serious oral diseases. Today, our guest is Nikita Evgenievich Ruzinov, an oncologist at the District Clinical Hospital in Khanty-Mansiysk. Could you please briefly tell us about your specialty and how you came into it? We'd like to learn a bit more about you, and then we'll start asking you questions.
Of course, when it comes to choosing a specialty, every medical student at the time of entering university usually doesn't really know what they want to become. Many in their first year always say, I'm going to be a surgeon.
Yes.
But more than half of people probably drop out after the first operations, the first dressings in the gun department. At the time of my studies, I tried to get general knowledge during the first 4 years of the academy to accumulate some kind of base, a portfolio. And already when the final years began, the more specialized ones, we would go to the departments, visit the wards. And during the oncology rotation, it really caught my interest. It became genuinely fascinating to me. I realized that I would focus more on this aspect and moving forward would go directly into oncology for my residency.
Let's probably start with oral cancer, with oncology. What are the primary or the main risk factors for its development?
Oral cancer, the main factor specifically for its development. The very first and main one is, of course, smoking this kind of chemical exposure, as well as alcohol consumption and the use of chewing tobacco. I think that in the future, after conducting better studies, we will also confirm the risks of all vape systems, similar vaporizers, and so on. The second most important factor is, of course, all inflammatory processes in the oral cavity. That is, these include glossitis, oral leukoplakia, and periodontosis as such, all of which also carry a high risk for the development of cancer. Another major factor to mention is oncogenic viruses, such as the human papillomavirus, which is actually very widespread not only among our population, but among people worldwide. Many patients are carriers of this virus without even knowing it, as it often presents with no clinical symptoms. The presence of this virus, when there is any decrease in immunity, can manifest itself, including in the form of cancer. I would also like to mention that another one of the most important factors in the possible development of malignant tumors in the oral cavity is chronic trauma. Chronic trauma does not simply mean the presence of a sore. This is most often currently associated with low-quality implant systems or the uncontrolled and improper use of braces. Wearing any kind of implant systems in general, including removable ones.
So am I understanding correctly that some kind of construction, whether removable or fixed, that chronically over a long period of time traumatizes the mucosa? Is that right? Is that a factor?
Absolutely right. Absolutely right. So it could also be gum trauma if, for example, a crown is improperly fitted. As a result, there is some kind of defect that persists for a long time. With chewing forces, even slight movement of the crown itself can cause trauma, including rubbing of the mucosa by the tongue, cheek, and similar effects. With braces, the situation is clear. Here, trauma to the mucosa of the inner surface of the upper and lower lips, as well as the cheeks, is entirely possible, which in turn can lead to oncological disease. Why does the dentist always ask us, even after a routine filling, for example, whether our bite feels comfortable now, if there's any rubbing, any discomfort, or if something needs to be filed down, adjusted, or removed to make it more comfortable? It's absolutely necessary to mention these things. You shouldn't just accept it and think maybe it'll settle down later, everything will be fine. Because the period during which we tolerate discomfort before the development of an oncological disease can actually be very short sometimes. Just 2 or 3 months is enough for cancer pathology to develop.
But what about patients who come in specifically with oral cancer where it's caused by, let's say, some kind of dental etiology or there's some dental trace present? What kind of complaints do they have? What do they say? When they come in, what do they talk about?
The main complaint is pain. That is, at the site of any defect, there is always a sensation of pain. Although many people say that if it's cancer, it doesn't hurt, it only hurts when it's already advanced. With the oral cavity, it's a completely different picture. It can hurt, it can cause discomfort. At later stages, radiation can join, and that is, the pain can migrate, it can move elsewhere. For example, a patient notices, say, an ulcerative defect on the cheek mucosa that hurts, but the pain radiates downward into the jaw and so on. Most often, this can indicate that the process has progressed further.
There are three types of oral cavity cancer, or three types of
Growth?
growth, yes. Could you elaborate a bit more?
Well, in medical terms, these are endophytic, exophytic, and mixed types. So the first type is when the tumor grows outward. For example, a patient with a lesion on the floor of the mouth might say, everything was fine, but now I can feel some kind of sickening with my tongue. That is, the tumor grows not into the deeper tissues, but directly into the oral cavity. The second type is when the tumor grows in a creeping manner, meaning it spreads along the mucosa with only slight involvement of the deeper tissues. And the third type is mixed, meaning there is both growth into the oral cavity and into the deeper tissues.
There are some memorable cases related to the dental, let's say, aspect of oral cavity oncology. Like what?
There is an interesting case of a female patient who wore removable denture systems for a long time, over 6 months, without taking them out. Because of this prolonged use, food would get stuck under them, and it was impossible to clean or disinfect them properly. As a result, our disease developed.
If a patient doesn't have the immediate opportunity to see a medical doctor right now, at this very moment in time, can they somehow determine it themselves? Or what else could potentially be a trigger or something similar to that?
The most basic thing we always say that a person is their own best friend, companion, and sometimes perhaps even their own doctor. It doesn't take much effort for anyone to simply examine their own oral cavity in the mirror. Not even necessary to look for tumors, but for defects, ulcers, and so on. There are, after all, many precancerous conditions. For example, it's easier to spot leukoplakia. Just open your mouth, take a look, and see that yes, the entire mucosa is pink, but there is an area, say, on the cheek, the gum, or the soft palate that is a different color from the surrounding tissue. The same goes for periodontosis, which I mentioned earlier. You notice that your gums are bleeding. There's some kind of problem, pain, maybe occasionally some pockets. This is what we're talking about with wisdom teeth, right? When food gets stuck there. All these pockets, chronic inflammations, these things should never just be left to observation. This is the kind of situation we're talking about. If you see it yourself, notice it, that's it. At that point, you should at least see a dentist so they can take a look, do an examination, and based on that, prescribe some kind of conservative therapy. If something appears that wasn't there before, that shouldn't be happening. We don't need that. This is also the most important point to keep in mind.
Yes, now, just a bit ahead of ourselves, but about seeking help, right? So the patient realizes, wow,
Suspects something.
Yes. Should they immediately make an appointment with an oncologist, or is there another way?
The simplest thing for the patient would be to see the local general practitioner for a basic examination. If the general practitioner examines you and realizes that the issue is more oncological in nature, they will immediately fill out a special form and refer you to an oncologist, either one at your clinic, if available, or if not, to the main regional oncology center. If they determine that the process is benign and there are no signs of malignancy, of course, they should immediately refer you to a dentist, for example, for conservative treatment of leukoplakia and similar conditions.
Now, as for the prevalence, if we talk about the region, for example, or about the Taiwan region, do you have any data, or maybe for Russia as a whole? What is the prevalence specifically of diseases, oncological diseases of the oral cavity or the oral mucosa?
Well, let's take the main trend in Russia over a 5-year period, shall we? Most often, of course, it is men who are affected. Due to our, perhaps I would even say, more aggressive lifestyle, it's clear that many men smoke more often than women, and alcohol consumption is also quite frequent. Additionally, men visit the dentist much less often than women. Women tend to take better care of their health in this regard. Among men, the average rate is about 6 cases per 100,000 people. So it seems like that's a really tiny number, 6 per 100,000. What is that really? But if you look at it in terms of millions, in cities with 1 million people, that's already 60 cases. For women, the incidence rate is about 2 cases per 100,000. Especially considering that dental care has become more accessible now, and patients are seeking treatment more often, specifically for prosthetics or for bite correction with things like braces. I'm sure that in the foreseeable future, these numbers may increase. Any chronic trauma in the body can lead to an oncological disease because our body is like a machine, and every cell has a built-in mechanism. That is, a cell appears, lives its life, dies, and another one takes its place. Cancer itself is a process where this mechanism a cell appears, lives, and dies is disrupted. A cell appears, lives, and then keeps on living instead of dying. In other words, the body cannot establish the systems that should exist in normal tissues. If we're talking about the oral cavity, the peculiarity of these tissues is that they try to divide and regenerate as quickly as possible. For example, if you compare a cut on the skin to a cut on the oral mucosa, you'll notice that in the mouth it heals in just a couple of days, and you won't even see a trace of it due to the high activity of the tissues. Therefore, when we talk about tumors in the oral cavity, they can also develop more actively compared to tumors in other locations or areas of the body.
Now we can talk about how things compare to 20 years ago and today.
Of course, the trend, the positive trend is definitely evident because more advanced drug therapies have appeared. That is, thanks to the introduction of immunotherapy into our treatment protocols, we are seeing very good survival rates and periods without disease progression or recurrence. Additionally, combining therapies such as starting with surgery, followed by radiation therapy, and possibly later adding chemotherapy also brings benefits. But the most important advantage is the increasing detection of early stage cases rather than more advanced stages when it is no longer possible to cure the patient radically.
Today you mentioned a patient who had half of their tongue resected. Could you tell us more about that case as well?
3 months before seeing an oncologist, the patient had a dental implant placed. So the implant and crown were in place, everything seemed fine, and there was absolutely no discomfort while chewing. Everything was comfortable for him. His bite didn't change in any way, everything was fine, but the patient did notice a slight discomfort while chewing, specifically on the side of his tongue. In other words, when chewing, the tooth would slightly touch the side of his tongue. For 2.5 months, the patient lived with this issue and didn't seek help from anyone. Noting that the area where the tongue was being rubbed from the usual trauma started to develop into an ulcer with occasional bleeding, he began to notice that even at rest, when he was just lying down or sleeping at night, he started experiencing pain specifically in his tongue. After about 3 months from the time the implant was placed to the development of the ulcer, the patient decided to see a dentist for an examination. The dentist immediately gave him a referral to an oncologist, and the patient was then referred to us. During the local examination, we observed that when the tongue is at rest and the patient is not speaking, there is clear contact between the implant site and the area of the ulcer, which was being irritated. A biopsy was performed on the patient, and an oncological disease was confirmed. Fortunately, at the time of examination and diagnosis, the process was localized, meaning the stage was not advanced. However, the treatment plan presented to the patient was a hemiglossectomy in simple terms. This is the removal of half of the tongue along with the tumor. There was also a suspicion that the tumor had spread from the lateral surface of the tongue to the floor of the mouth. A resection was performed, and tissues from the floor of the mouth were also removed. At present, the patient has a lifelong speech defect, meaning he constantly lisps. The main problem that developed was specifically with the implant system, which over the course of 2.5 to 3 months caused him some minor discomfort and irritation.
Well, that's actually the point I wanted to elaborate on a bit more. So we're talking about stress, but for example, there's another factor, like for the skin, it's the sun, right?
Yes.
Are there any other reasons for the mouth, for the oral cavity, any other causes? So stress, well, let's say both obvious and not so obvious ones.
Well, these are more like potentiating factors. They're not exactly direct causal factors as such. Dietary habits, action, nutrition, really. Why, for example, is it that in Asian countries there is most often a pronounced pathology with cancers of the gastrointestinal tract and consequently cancers of the oral mucosa? It's the consumption of spicy food, very high levels of spiciness, increased acidity, and possible reflux. Surely, many patients have even noticed themselves that when they have heartburn, they look and see some kind of black coating on their tongue. And this is one of the warning signs that there is reflux into the esophagus, most often at night, the so-called gastroesophageal reflux disease, or GERD. As a result, its acidic, highly aggressive content can reach the oral mucosa and also indirectly cause inflammation. And from there, the process can continue, eventually leading to the development of cancer. The nature of your diet is also very important. Hot food. We are not creatures who can drink boiling water. Our bodies simply aren't designed for that. Of course, many people love to drink hot tea, coffee, and so on. But everything is good in moderation.
Nowadays, technology in medicine has advanced so much that this biopsy you're talking about, by the way, a biopsy is when a small piece is taken from the area suspected of having cancer, and Thanks to such a complete biochemical analysis, as you mentioned, they can even determine the specific protein, meaning that the same type of cancer can be treated differently thanks to modern diagnostics.
Absolutely right. Classical chemotherapy, yes, which is used without identifying these specific markers, will be toxic both to the tumor and to the body. Now medicine is moving away from that. It's evolving, drug therapy is advancing, and in many tumors, they are finding those specific targets that can be affected precisely only there. In other words, without causing pronounced toxic effects, so that the patient can tolerate the treatment well, without issues like hair loss, nausea, liver toxicity, and similar side effects.
Alopecia is hair loss, as seen in all patients.
This is what oncology patients most often ask themselves. If we start chemotherapy, how quickly will I lose my hair?
Now, together with Nikita Evgenevich, we will take a direct look. Nikita Evgenevich has sent us photos of his patients. We'll see what it really looks like right inside the mouth. Be sure to follow the link, you'll see it. We'll attach it and discuss what we are actually seeing, what it is, so that we can help you as much as possible, really encourage you to focus on this, and of course, to some extent, scare you so that you seek help in time.
In the first photo, we see leukoplakia affecting specifically the body of the tongue on its lower surface. So we can see how the color itself differs. For example, if you compare it to the right, you see normal pink moist mucosa where the deeply situated capillaries and blood vessels are clearly visible, and so on. And what we see on the left is an unclear whitish lesion, different in color from the rest of the oral mucosa. So this is a classic example of leukoplakia, which can directly lead to tongue cancer. Here we see a small ulcerative formation, also showing signs of leukoplakia. So either of these could be considered a risk factor. We can see that the leukoplakia lesion on the mucosa is located right next to the tooth. And as we can see from the photo, the tooth itself has a carious lesion. So it's likely that the tooth is damaged and is slightly traumatizing the mucosa. Leukoplakia will never be identical to normal tissue. So very first thing is that it differs in color, in shape, and it can also differ in moisture. That is, it tends to be drier. This aspect.
And is it always white like that?
Whitish.
Is it ever black or green?
No. It's always more of a whitish color. We also see that the patient has periodontosis in the upper jaw, as we mentioned earlier, which is also a possible sign of a precancerous condition. So here, there's not only a risk of developing cancer of the buccal mucosa, but also, for example, cancer of the gum mucosa in the upper jaw as well.
And here, yes, I actually had a question. What are we seeing here? Are we looking at the gum here?
This situation needs to be differentiated specifically from a viral one, the human papilloma virus. So these aspects need to be examined.
Is it right here?
Yes, right here. These small manifestations are directly on the gum. This also needs to be differentiated, examined. And
little nodules, right?
Yes, a nodule on the mucosa. So it can also protrude above the level of the mucosa and slightly change its color.
Now here we have a case of actual mucosal cancer.
Here we can already see, yes, a malignant disease. So locally, we see a process that is completely different from even the typical photos we showed earlier. In other words, we see a characteristic growth in the oral cavity. So this is not of a inflammatory nature, right? We also see the main ridge changes in the tissue, the structure around it, and most likely on palpation, the patient will experience pain at this point. So even just by palpating with a finger, the patient will definitely report significant pain. Here, the cause of the disease, again, the gums, may be connected with, if we take the bottom photograph, yes, most likely there is some kind of problem. But again, if we look at the roots, we see a picture of periodontosis.
Yeah.
That's exactly it.
Is this already a tumor decay or not yet?
This is not a breakdown yet. This is not a breakdown. Tumor breakdown will occur with a larger tumor mass when it can no longer nourish itself, and thus...
Well, there's already some kind of smell here, right?
Most likely, in addition to pain, the patient will also complain about bad breath from the oral cavity. Well, even if you look at photos like this, to be honest, this is not something that developed in a day or a week or even 2 weeks for the patient. So it's clear that the patient has probably been bothered by this for more than 1, maybe even 2 months, because the tumor mass here is quite significant.
Mm-hmm.
So all this time, as we mentioned, from the very first day, there would be pain symptoms. Most likely, the patient has been living with severe pain for 2 or 3 months. And only now has he come in for an examination by a doctor, where primary assessment was carried out, and the situation we see was documented.
And most importantly, what we have learned today with our dear and valued viewers is that right now, if a patient comes to see their doctor at least once every single year, it truly doesn't matter if it's a dentist.
Even just for a routine checkup. Many people think if I go to the dentist, they'll find cavities and start treating everything. Oh, I really don't like all that and I'm afraid of it. At least just go in for a checkup so they can examine not just your teeth. The mouth isn't just teeth, it's also the floor of the oral cavity, the palate, the gums, the cheeks, and the tongue. All these aspects must definitely be taken into account and monitored. It all depends on the patient. The sooner they come in, the sooner there's a chance to either find a precancerous condition or detect a disease at an early stage. And treating a disease at an early stage always gives an extremely positive prognosis for the future.
So there's no need to be afraid?
No need.
Definitely, in today's world, again, I want to stress in the current realities of our healthcare, we will absolutely help the patient if it's done in a timely manner, right?
Absolutely right.
Yes, it was a pleasure and very informative. I hope our subscribers feel the same way. So be sure to ask questions, write them in the comments. We will definitely pass these questions on to Nikita, and
We answer.
we will definitely answer Evgenievich as well. So once again, thank you.
Thank you for the opportunity to do some educational outreach. I think that's also an important thing in our time.
Yes,
I think patients will find it interesting.
thank you.
Thank you.
Stay healthy, take care of yourselves.